Welcome to the fifth episode of Let's Talk About Access. Today, I'm very happy and honored to have with me John Lucas, Chief of Surgery at Greenwood Leflore Hospital in Mississippi, and immediate past president of Vascular Access Society, and most importantly, very passionate vascular access surgeon. Definitely somebody who knows about fistula, and definitely somebody who knows how to do distal fistula. And I thought we can take advantage of his experience and get his tips and tricks on how to make these fistulas better. John, hi, welcome, and thank you for accepting my invitation.
Well, it's a real honor. Thank you, Alex.
So, John, I believe you are mainly doing access surgery at this point.
That's correct.
Yeah, you're a high volume access surgeon in Mississippi. How many fistulas are you doing per year, and what is the percentage of distal fistula you're doing?
So I do about 300 to 350 new accesses a year. I would say 2/3 of those are distal fistulas. And the Snuffbox has become a particular interest of mine recently, and it's gone from a small fraction of my wrist-based fistulas to almost 40% of my fistulas this year.
40% from the
Of
entire
the
number of your fistulas.
of the wrist-based fistulas, so almost half of the ones that you would normally say is a radiocephalic fistula have been Snuffbox fistulas.
Okay. And how come this changed later in your career?
So unless you're exposed to something, you may not understand what the benefits are. And 4 or 5 years ago, I saw a presentation by Dr. Ozaki's group up in Harvard, and they were highlighting Snuffbox fistulas. And it just went off in my head that, I ought to look at those more. And so when you look for something, you can find it more often. And so scanning all the way down to the snuff box, the anatomic proximity of the two vessels is the closest of any place that we do fistulas. It's very easy to do, takes 10 cc's of local and just a little bit of sedation. Also, I found that in probably 10% of the accesses that I thought based on ultrasound exam in the office I would do at the elbow, so a proximal radiocephalic. If I have anesthesia do an axillary block and rescan the patient, probably 10% of those I can convert to a snuffbox fistula because the cephalic vein is now dilated sufficiently so that I can be confident that a snuffbox fistula would have a high probability of success.
John, do you have the same decision making like Tip Jennings, meaning that he will easily go to proximal radial if he has doubts, or you are going to take your chances and try for a distal if you think it's going to work?
So the way I evaluate the patient is I feel for the pulses. So if I can feel a good snuffbox pulse, then I'll look for the cephalic vein harder to see if I can connect it there. If I don't feel a good snuffbox pulse or I don't feel a good radial pulse, then I'll go to the antecubital area where I preferentially do a proximal radiocephalic. But if I can feel good distal pulses, then I'll make extra effort to evaluate the vein to see if it's suitable for the more distal fistulas. I really believe that we've come to understand more recently the detrimental effect of the high flow fistulas that occur when we're connecting it to the brachial artery, from congestive failure to more outflow stenosis to more aneurysmal formation. So I think in general, the more distal you go, the lower flow fistula, as long as you have some confidence that using healthy vessels, you'll get a usable access.
So you verify that you have a good pulse in the artery, and then you search for the suitable vein. How do you define this suitable vein? Is it a quality, size, continuity?
So, when I'm interviewing the patient, I establish they need a fistula. I put up tourniquets above the elbow on both sides, have their arms dependent, and ask them to squeeze their fist a couple of times while I'm getting the rest of the history. And then I'll ultrasound them. And I always have my machine set on the same setting, so I don't usually do a manual measurement of the vein, but it needs to be compressible. It needs to be of uniform or enlarging diameter from distal to proximal, and it needs, and that's the main thing. So I'll compress it as I'm going up and down, making sure that is compressible, look at the thickness of the wall to see if there's any scarring that might have occurred, because those veins are the ones that are most commonly used for IVs or blood draws. And so forearm cephalic veins are unfortunately have their share of scar tissue and are not usable.
And so in essence, because you have such a huge experience, you have the settings of the ultrasound at exactly the same depth. So your
Correct.
brain does the measurement immediately. So you're probably able to say this is 2.5, 2.8, 3, something like that. But do you actually have a cutoff that you wouldn't do it if it's 1.9 or not necessarily?
So if I would think that the veins that I choose not to use are less than 2 millimeters in diameter.
Okay.
And I think it's gonna be on a younger person, I would be more apt to push the envelope to try to use smaller veins. In a 70, 80-year-old, I would be more likely to use larger veins more proximally, just because their need for an access is not gonna be as long as that 20 or 30-year-old would be.
Do you take under consideration the distance of the vein to the artery?
So in the Snuffbox area, it's always going to be just a couple of millimeters. Oftentimes, the lateral branch of the cephalic vein near the wrist is the one that is better, because the main cephalic has been used for IVs right over the head of the radius. And so, looking for that, it makes it a little more challenging, but if it's a healthy vein going out, then it's worth the extra effort to make a second incision and transform or transpose that vein.
So John, let's say you have this posterior branch of the cephalic vein going here,
Right.
and then it goes higher and it joins the larger vein at the limit between the distal and the mid third of the forearm.
Yes.
Would you go and do it more distally and surge the vein back there, or would you do it a bit more proximally if the artery and the vein are closer?
I try to utilize the extent or the longest segment of cephalic vein that I can. I think the problem we see in dialysis units so much is area cannulation and formation of aneurysms. And if you give them only a short segment, then that's the only choice they have. If you can give them a really long segment, then there shouldn't be an excuse for not doing rope and ladder cannulation and avoiding the aneurysmal changes that happen with area cannulation. So I really do try to go as distal as I can on the vein, even if it requires doing 2 incisions and tunneling the vein over to the artery.
Okay. And do you find any difference in your results in terms of success if you have to transpose the vein in a further distance, from the artery?
So I think the biggest challenge is rotation of the vein. And I think any kind of rotation of the vein potentially sets up a turbulent area that'll generate stenosis. So that's what you have to be extremely careful of. And I'm not sure that I've become perfect in that yet. And so that's still a challenge. But I think when you mobilize the vein, you should mark it before you've completely mobilized it, so that the portion that's anterior is truly anterior, and then try as best you can not to rotate that when you pull it over. And I think that's the beauty of the snuff box, is because they're right on top of each other and your potential for rotation is much less.
So you're marking systematically the vein before bringing it over for the
Yes,
anastomosis.
yes.
What are you using for marking it? Like a marker or whatever?
I just use the sterile marker, blue. I'm not sure of the actual dye, but I just make a few dots on top of the vessel so that I can orient it properly when I've moved it from lateral over to the artery more medial.
And you do this before sectioning the vein.
Yes, yes.
And would you section the vein completely and then open it with the pot scissors to do a putz in the vein? How do you prepare the vein?
So I typically use Dr. Chenoy's technique of a P slot if I'm doing the cephalic vein in the forearm. And I do that because I find it useful to use the open end of the vein to pass a probe to relieve any spasm that might be in the artery or in the outflow vein. And occasionally, particularly at the wrist or even Snuffbox, you pass that rigid dilator up and you'll hit a little place and it'll pop through. So there's a little scar, synecdoche, or something in that vein, probably from an IV or blood draw that you've treated, and now you have a wide open fistula. I think some of those really tiny fibrous bands you don't really see well on ultrasound every time. So I take advantage of that open end of the vein after I've done the anastomosis in order to probe the artery in the vein, and then I'm have a good thrill when I leave the operating room, and I'm not wondering, was there spasm and is it going to improve later on or not?
So even if you're done and you take the bulldogs off, you have a good thrill, you will pass the dilators, or you only do it if you don't have a good thrill?
So I'll pass the dilators just through the anastomosis and just a little up the vein, just to make sure that there's no narrowing at the heel. But yes, it's almost universal that I'll pass it. For brachial-based fistulas, I don't do that. I usually do an end-to-side anastomosis and try to make a smaller anastomosis. And recently, I've been using Vascu for the majority of my brachial-based fistulas in hopes of limiting future flow and also improving or lessening the swing segment stenosis that you sometimes get anytime you're bringing the vein over to the artery.
So that's for brachiocephalic and brachiocephalic. So you're not using the Vascu for distal fistulas, are you?
Use it when I have larger vessels, but I don't think it fits into the Snuffbox anatomy. So I have not used it at the Snuffbox. And if I have small vessels, I really haven't used it. For the medium to larger vessels, I have. So what's medium to large, 3.5 or more, as far as the diameter.
But also, if you're doing the Chenoy technique, like I do the same thing, then you cannot use the Vascu because the
It does not.
Chenoy comes, yeah.
That's correct. So it's a trade-off, and so if the vessels are small, and I think making sure it doesn't have some spasm is important, then I won't use the Vascu device, because once you've done that, it is quite cumbersome to remove the sutures for the stirrups, elevate the Vascu, and then reopen your anastomosis. So I've chosen to use the Vascu and the brachial-based fistulas, and some of the proximal radiocephalic fistulas where the arteries are larger.
Okay. And I believe are you still using these clips for the anastomosis, or you're using
So
Troy?
they've sort of priced themselves out of what our hospital can afford, and so everything is 7-O-proline for my anastomosis. And I do interrupted for radial-based fistulas, distally for radial-based fistulas at the elbow, and brachial-based fistulas, I'm using a continuous suture.
So if you do like a Semino fistula, you do interrupted sutures?
I do 5 interrupted at the heel, and then I run across the sides and the toe.
So you will do outside, tight 5 times at the heel,
Right.
and then
Yes.
you do a running suture all the way around?
Yes.
And this is because you find that you have less risk of having a stenosis at the heel by doing that?
So there is no good data out there. There was a paper in 2005 or so that was presented at VASA from Birmingham, England, where they did a randomized trial of interrupted versus continuous sutures for radiocephalic fistulas, and there was improvement in their patency, though it did not reach statistical significance. And I think it would likely have had they had a larger size, but in their sample size, it did not reach statistical significance, though there was an improvement. And since I used the anastoclips, and I thought that they did help my patency compared to prior use, then I've adopted an interrupted technique, at least for probably a third of the anastomotic length with those 5
Okay.
sutures at the.
What is your, John, what is your success rate, if we can define success rate? Let's say the fistulas that will mature in terms of primary patency of your distal fistula.
So when I shared with you my presentation that I gave at VASA, and the more distal fistulas actually had a longer cumulative patency than the more proximal based fistulas, and there were fewer interventions. So I think there's probably a few more early interventions that have to be made in a distal fistula. I mean, because flow is lower, side branch ligation is more important. You know, in the upper arm, if you do a brachiobasilic, you've ligated all the branches at the time you do the transposition. But for a snuff box, since you haven't ligated any branches except the very distal part of the cephalic vein, you may need to go back in and ligate some early side branches. Side branches above the mid forearm are usually not significant because your arterial needle is going to be closer to the wrist, and the only requirement for the venous needle is that it's a large enough vein without outflow obstruction that can accommodate the return of blood that's been cleaned by the dialysis machine. It does not have to have 500 of flow or 600 of flow. You can put the vein in the opposite arm if you have an old fistula that's not working, but the vein is still open, particularly above the elbow. So I do measure the flow in the brachial artery, radial artery, and the cannulation segment of the cephalic vein, and I'll measure it with and without compression of side branches if flow is on the lower side, to see if intervening and ligating those side branches would increase the flow in the cannulation segment such that it'd be a usable fistula.
Okay. And do you find any difference in terms of maturation success between your Snuffbox fistulas and your wrist fistulas, your more regular Semino fistulas?
I think there's a little less. I think there are more that don't mature because of low flow, because you're going after the radial artery has branched, and if there's any atherosclerotic disease, it may be such that it doesn't really dilate enough. So, you know, I think that that's a part of the learning curve, is what is the quality of the vessel at the snuff box that you can use to have a matured fistula. And I may be moving a little bit more toward being more selective about that artery, because I think that's the main limitation if you've identified a good cephalic vein, is what's the quality of that artery and can it actually dilate. Because oftentimes when you do a radiocephalic at the wrist, they'll come back and they'll already have 500 or 600 at the second week of post-op. But a snuff box fistula may only have 200 or 250, but when they come back in a month, they'll have 500 or 600. So you're counting on more dilatation and larger percentage increase in flow over time in that snuff box to get it to mature. So I think you have to be a little more patient. So fortunately, in my area, there are a number of nephrologists that send me patients with CKD4. And so we've got 3, 6 months, or a year to get a fistula to mature. I think the calculus is different if they come in and they've already had a catheter for 2 months, or they're on their second or third catheter. Then I think you need to make a choice for a larger, healthier vessel that'll mature quicker. But if they're the CKD4, I don't have a problem with doing a snuff box and then, waiting for 3 months or 6 months if that's what it takes for it to mature.
John, if the patient has a central vein occlusion in the same side you want to create a fistula, but you have good distal veins, is this a contraindication for you, or would you ask a venogram?
So I do get venograms for patients who are already on dialysis and who have some kind of central port or pacemaker, something like that, that may affect the patency or the stenosis of the central veins. And even in the face of an obstruction, if they have good anatomy and that's the side that has the best veins, would discuss with the patient. There's a chance of you getting swelling of the arm because of the central occlusion, but you have healthy vessels and the swelling will be least if we choose a snuff box or a very distal radiocephalic fistula compared to any place else. So, I lay that out, and if that's the best option for the patient, then that's usually what we decide to do.
Are you putting any grafts ever?
Yes, so I'd say, looking at my percentage of grafts, it's about 10 to 15% depending on the population. So, is it very old patients who may not have a long life expectancy or that have had most of their veins used up, or, are they getting referred in from someplace else with several failed fistulas and they don't really have a good option? So the younger patients, I'd say it's 5%. Or maybe at the most 10, and in the older patients, it's 10 to 15%.
Is obesity a factor for you for selecting your technique? Would you do a brachial vein and elevation or elevation of the brachial vein, or would you prefer a graft, for example?
So, as you may know, Mississippi held the title of the fattest state in the United States
I
for
thought it
like
was
6
Oklahoma.
years in a row,
It was
and
all
so
Oklahoma?
we lost it to West Virginia, I think, last year, but
Okay.
we see a large number of patients. In fact, I have one that I want to highlight at a meeting who had a BMI of 74 that I did official, but you'll be surprised at how good the veins are in these obese patients because nobody else has been able to put a needle in it, at the forearm or the wrist. And so I do a lot of distal wrist-based fistulas in the BMI 40 to 60 or so range, and you just have to accept the fact that you come back and you elevate it. I usually do a transposition for that. I divide the vein near the previous anastomosis, leaving a cuff of probably 2 centimeters, and then dissect the rest of the vein out as close to the large deep branch as you can because you want to leave a good outflow. And then I'll, take the vein out, retunnel it. So instead of, 6 to 12 millimeters deep, it's 2 to 3 millimeters deep and reanastomose it.
So what would be the main reason that you would choose a graft for a patient?
So you don't see a good vein or you don't have a vein that would reach. I mean, there occasionally, and we see some of these patients that have just massive amounts of fat between the elbow and the shoulder. And so taking a vein and going from deep to superficial and back to deep again to get to the artery, you may not leave much cannulation segment at all. And so if the basilic vein trifurcates above the elbow in a really obese patient, you may not have enough length. But if it has a dominant branch that's going to the forearm, then you can go below the elbow and get enough length so that when you do your tunneling, you can make it reach and have a cannulation segment that's adequate.
Do you ever reject a patient for a fistula? Do you ever say, I'm not going to do a fistula here, just leave him with a catheter?
So I do have I mean, yes, I mean, there are definitely folks where the extra cardiac output that results from a fistula or graft might tip a patient over. They come in, they've got a catheter, they're short of breath in a wheelchair when they're talking to you. You just may say, for the time you've got and for the condition of your heart, a catheter's the best. And there are other patients that I see that might have a vein where if they were younger, I might give it a try. It's going to be a lot of surgery for transpositions or other things, and it's not a high likelihood of success. I'll say, come back when you're close to dialysis and we'll put a graft in. And so instead of trying to do a fistula with a very low probability of success, I'll say, I'll send a note to the nephrologist. These are CKD4 patients. I'll say, send them back when they're about a month from needing dialysis, and we'll expedite getting them in surgery. And they can usually use their access in 1 to 2 weeks.
Okay. And John, how many fistulas have you done so far in your career? How many thousands?
Well, I only really started tracking them from 2011, but I've done over 4,700 primary fistulas and 5,500 total new creations. So that's 800 or so grafts and 4,700 primary fistulas.
And would you identify some technical pearls that, let's say, you discovered over the years or the last 10 years that you said this technical modification makes a difference, like, the 5 stitches at the heel, as you mentioned, or something particular that you find transformational in your results?
Well, I think realizing that you can go distal and still have good results, I think you do have to be, careful with your technique and handling the vessel. I think the rotation of the vessel when you're bringing it from one location to another by the artery is just critical. And I can tell you that occasionally I have done anastomosis and it's a little bit pulsatile. It doesn't have that nice continuous thrill, and I've looked up and there's a little bit of torsion, and I've taken down the anastomosis. I've opened up the artery a little bit further, and I've opened up the vein in whichever direction I think it needs to twist and redone that anastomosis, and then it's a really nice soft thrill. So rotation of the vein, I think, is one of the more critical elements, and I think that's probably why both the percutaneous fistulas and the radar technique have a high maturation rate or success, because you're not rotating the vein at all in either of those two techniques.
Okay. So just to make sure I understand your technique, it would be that you mark the vein, let's say the 12 o'clock wall of the vein, and you
Right.
will make sure that the 12 o'clock stays 12 o'clock after you have done the anastomosis.
That's correct, yes.
Okay, perfect. Well, John, to be honest with you, I was aiming for a 15 to 20 minutes episode, but you had so many interesting things to say that I had to ask you more and more and clarify and everything. So I think I will wrap it up here. I will probably bother you again in the future and ask you to meet again and discuss more technical aspects, because there are very few guys around like you, Janik, John Ross, and other people with so much experience in AVF. And I think we need to make sure that we take all this wisdom and technical tips and make sure we share it with the younger colleagues.
Let me tell you one thing that I try to stress is that the ultrasound examination of the vein should be done by the operative surgeon. It should not be by the technologist. I just think there's too much information that's not conveyed by static imaging and some markings on a anatomic drawing about, the quality of the vein. It really has to be done by the individual who's creating the fistula.
Yeah, I
And,
think
and
we
don't hesitate to repeat that exam at a time of surgery, particularly if you're doing it with some kind of axillary block, because you may be pleasantly surprised that that vein is bigger distally than you had estimated prior.
Well, John, thank you very much for joining me. Happy 4th of July. Wishing you a great celebration, and I'll see you soon. Thank you very much, John.
Appreciate that invitation. Good talking
Thank
to you,
you.
Alex.
Thank you.